Shall we start?
Yes, sir.
Yes, sir.
So if you could make your screen full screen, it would be better.
Pardon me? Hello?
PPT you're sharing, could you please make
Yeah.
it full screen?
Yeah. Is it okay right now? It's visible?
Yeah.
It's moving?
The
It's
audio
moving,
is...
right?
Yes. Please go ahead, sir. All set.
Thank you. Good evening, everybody. So, as far as the discussion of critical care medicine topics concerned, this I would be taking as a last topic in the critical care medicine. I was in dilemma whether to take this particular topic in discussion or not, because this is a very vast topic and a very vague topic. But there is a chance that you do encounter your questions as an UG, both in your final exams as a major question, or there are some aspects of interest in the MCQ world also regarding this particular ARDS. And apart from this, as far as PG education, the ARDS, they should be knowing in detail. Let's cover this topic as detailed as possible, because this is a very, as I told you, very vague topic, and we cannot take a complete ARDS lecture in any single class. So I promise to be incomplete here. So you need to be go back again and study regarding this from various points of view. So coming to the discussion, we know first of all, the acute respiratory distress is a syndrome. It's not a single disease, it is a syndrome. So there is a culmination of manifestation towards an ARDS from many of the causes. So historical importance being, the first was discovered in the early or the mid-90s. This was the major case series by the famous Dr. Ashbach. He discovered some multiple number of patients suffering from an acute respiratory distress, which are having a similar phenotypic variation. And before coming to this, the first ARDS picture was actually discovered during the Vietnam War. What happened was many of the wounded soldiers were airlifted via the helicopter to the hospital. And in the hospital, what they observed was some subset of patients were progressing into a hypoxia. And this hypoxia was not responding to an oxygen therapy. Even though patient did not have any chest trauma, patient did not have any lung contusion, etc., the patient were progressing to hypoxia from injury to other parts of the body also. So that is how the terminology came as the respiratory distress syndrome. And initially, when they discussed it, they discovered it to be a flooding of an alveoli, that is an alveolar edema occurring similar to the condition called as cardiogenic pulmonary edema. That's why they labeled it as non-cardiogenic pulmonary edema. Here it is, they thought it is similar to pulmonary edema, but the cause is non-cardiogenic. And it is similar to what is called as neonatal respiratory distress syndrome. That's what they discovered initially, or that's what they thought it initially. That's why initially ARDS used to called as adult respiratory distress syndrome to differentiate it from a neonatal distress syndrome. But later, it's been found out that this has been a separate entire issue, which is not similar to the neonatal respiratory distress syndrome, which occurs due to preterm baby, especially due to lack of surfactant. So this is a slightly different variety. That's why they changed the terminology to an acute respiratory distress syndrome instead of adult respiratory distress syndrome. So when they first discovered it, what they discovered was they defined this particular disease as a syndrome of severe dyspnea. The patient used to have severe dyspnea and tachypnea and cyanosis. That means they used to have a respiratory distress, which was refractory to oxygen therapy. And during the investigation, they found out that the patient had severe loss of lung compliance, and they used to be getting a lot of benefit, a lot of improvement with the provision of positive airway pressure and some possible benefit to the steroids. And in the histology, they used to have a diffuse alveolar infiltration. So this is what has been first described in 1967. And believe me, it's been more than 50 years, and we are still in the same page of the therapy. Apart from some minor variations, we really haven't done anything to prevent the mortality in ARDS as far as now. That's why this has been a lot of gray areas as far as ARDS is concerned. Each patient is different. I think as we are moving from an era of an evidence-based medicine to the precision medicine, the mortality, I think, is going to come down with the precision medicine. The individualized therapy is going to help better in ARDS compared to what you call the standard of care. So to define it, an acute respiratory distress syndrome is a distinct type. It is not all acute respiratory failure is not ARDS. So ARDS is a separate type of an acute hypoxemic respiratory failure, which is characterized by an acute abnormality in both the lungs. And to define this and to manage this, it is not a simple disease. It's a very severe disease. And patients are very, very rapidly developing. The patients coming to you, the hospital in the morning may die in the evening of ARDS if you don't manage it properly. And it is frequently and very frequently life-threatening, even with the proper treatment. Even with a good treatment, a severe ARDS, the 45 out of 100 patients are going to die in case of severe ARDS. And this hypoxemic respiratory failure, which is developing an acute abnormality, is usually not explained by the fluid overload and the cardiac failure. So this is what labeled as an acute respiratory distress syndrome, or also called as non-cardiogenic pulmonary edema. So this was similar to the pulmonary edema. That means your alveolars gets with the fluid, but the cause is not cardiac. So what is actually causing this an acute hypoxemic respiratory failure in this patient? So we know that for the pulmonary edema to occur, we know that the basic pathology is there is been an imbalance in the filtration, and there is a fluid removal from the alveoli. We know that there is a capillary and there is an alveoli. We have an alveolar capillary membrane. Even though there is slight amount of fluid is getting filtered through this, because this is a semi-permeable membrane, the amount of fluid, whatever is filtered, this can be removed by the lymphatic system of the alveoli. So this pulmonary edema occurs whenever there is either an increased pressure or whenever there is an increased permeability in the vascular membrane. So this ARDS occurs due to an increased permeability in the alveolar capillary membrane and not due to an increased pressure in the pulmonary capillaries. So this is usually a cause in cardiac pulmonary edema. Whereas if the flooding of the alveoli occurs with respect to an increased permeability of the alveolar capillary membrane, this is what is causing the ARDS in patient. So to go to the microscopic level, we know that alveoli to be patent needs to be dry. The pulmonologists believe that the dry lungs are better lungs. Please remember this. So the alveoli needs to be dry. So we have got an alveolar capillary membrane, which is lined by the capillary endothelium and the alveolar epithelium, which maintains the patency, allows only for the gases to exchange, which is the basic function of this. So whenever there is an injury to this alveolar capillary membrane, be it on the alveolar side or it on the capillary endothelium side. Whenever there is an injury, there occurs first an extravasation of the neutrophils. So the neutrophils start appearing into the alveolar cavity. So these neutrophils, they stimulate an inflammatory response. They secrete various of the cytokines and chemokines, ultimately damaging this alveolar capillary membrane, making it permeable to many of the larger proteins like albumin, so that lots of fluid and the proteinaceous material moves into the alveoli, flooding the alveoli. And this causes an alveolar collapse. So this is how the ARDS usually develops, from a dry patent alveoli to the very wet alveoli, which is filled with a proteinaceous material, the debris and the dead cells. So to understand it at the microscopic level, again, we know that we have the capillary endothelium here, and we have an alveoli, which is basically contains the type 1 and type 2 pneumocytes. If you see this normal alveoli, this is dry, and it contains the alveolar type 1 pneumocytes and type 2 pneumocytes and some channels, and there is a capillary endothelium which has got a smooth moving of blood cells, which allows for the gross exchange. So whenever there is an injury to the alveolar capillary membrane, be it from the alveolar, be it on the capillary side or it in the alveolar side, the various insults can cause this injury. We will study in the coming slides. So any injury, what it does is it damages the alveolar capillary membrane, so it alters the integrity of this membrane. So this first causes an extravasation of the polymorphonuclear neutrophils. So this polymorphonuclear neutrophils it secretes the various cytokines, ultimately causing the severe damage or gaps in the capillary endothelium, making the fluid from the capillaries moving into the interstitium and the alveolum. So this injury also causes damage to the type 2 pneumocytes. So this protein-rich edema fluids gets accumulated inside the alveolum, so that the gas exchange is getting hampered and ultimately causing the alveolar collapse. So this is a very, very important thing. So as I told you, any inciting event causing an injury to the alveolar capillary membrane causes release of an inflammatory mediators, which injures the alveolar capillary membrane. So this causes a migration of the blood cells from the fluid from the capillaries into the alveoli, causing a pulmonary edema, which is non-cardiogenic, which is filled with an exudate. So since the alveoli is filled with the fluid, this impairs the gaseous exchange. So these released inflammatory mediators also causes some amount of bronchoconstriction. So this will also hampers the gaseous exchange. And we know that hypoxia causes a severe vasoconstriction response in the lung vasculature. So there is a vascular narrowing and the obstruction. So this will ultimately also affect the gaseous exchange by increasing the dead space. And there is a damage to the type 2 alveolar cells. Type 2 alveolar cells are implicated in the surfactant production. Since the damage, the surfactant production is decreased. Hence, there is an increased surface tension, causing a decreased alveolar compliance and recoil, which causes anaphylactasis and reduced lung compliance in the injured lung. So basically, there is a reduced gas exchange, and there is a decreased lung compliance. Compliance simply means an ability to expand when the air comes in. So the lung compliance is reduced and the gas exchange is reduced. So this reduction of the lung compliance was considered to be the hallmark of an ARDS. We know that many of the diseases impairs the gas exchange. For example, if you see this pneumonia, simply community acquired pneumonia, or there may be a viral pneumonia which may cause a bilateral pneumonitis, so which actually impairs only gas exchange, but the lung compliance is usually not reduced. Since in the ARDS, both the gas exchange is limited and the compliance is also reduced, which makes it as an unique combination in causing an ARDS. That's how pathologically it is different from other causes of acute respiratory hypoxemic failure. So, to repeat again this, there are three main consequences. Actually, there are two main consequences. First is, as I told you, impaired gas exchange, which causes VQ mismatch and the physiological shunting. As we discussed in the class of respiratory failure, shunting usually does not respond to oxygen and ultimately causing an increased dead space. So initially there is a hypoxia. If this is not been sorted out, it will progress into hypercarbia. So initially patients will have type 1 respiratory failure. They may progress to type 2 respiratory failure if disease becomes very severe. Since there is a reduced lung compliance, the lung is very stiff, it is non-aerated, very difficult to ventilate. And as I told you, this hypoxemia causes hypoxic pulmonary vasoconstriction. 25% of ARDS patients who are on mechanical ventilation can have a pulmonary hypertension, which is a very important thing. This is the basic why some people have tried an inhaled nitric oxide as a treatment modality in the management of an ARDS. So many of the people also think that there is an associated pulmonary hypertension. Again, to understand the pathophysiology, if we injure the alveolar capillary membrane, so there occurs an interstitial and an alveolar edema formation. Since the lung is filled with the fluid, the lung compliance is reduced, the work breathing has increased. And if there occurs a diffuse alveolar filling, there occurs a VQ mismatch and shunt, causing severe hypoxemia, which is resistant or refractory to the oxygen therapy. And due to damage to the type 2 pneumocytes, there occurs a reduction in the surfactant production, and there occurs an end expiratory alveolar collapse. We know that we have got an alveoli. This is during inspiration. This is during expiration. So when the air comes in, the alveoli enlarges, and the air goes out, the alveoli reduces in size. So this reduces, will not collapse the alveoli, because normally there is a surfactant which prevents the alveolar collapse at the end of the expiration. So whenever there is a less surfactant, there occurs an end expiratory collapse. This is a very, very important thing, because a collapsed alveoli takes more pressure to open the airway. That's why people usually gives response to the PEEP, that is positive end expiratory pressure. That is what is PEEP means. We are keeping the alveoli open at the end of the expiration. We are not allowing it to shut down completely. And there occurs many microbiological adverses, like the platelets get activated, your endothelial cells gets activated, which causes a thrombosis or sometimes an obstruction and the destruction of the lung vascular blood, which ultimately increases the dead space, causing high minute ventilation, hypercarbia, and sometimes progressing into right heart failure. And when these inflammatory cytokines spills into the systemic circulation, which may progress into the multi-organ dysfunction, which is usually the most common cause of death in case of an ARDS. So we have understood the pathophysiology here. So this pathophysiological duration has been divided into three very important phases, called as an exudative phase, the proliferative phase, and the fibrotic phase. Some questions have appeared regarding this also, so it is better to understand this. So we have got a normal alveoli. During the initial 1 to 7 days, it stays in the exudation phase. That means whatever we discussed till now, we discussed the exudative phase. There occurs an injury to the alveolar capillary membrane, the neutrophils enter, lots of secretions of the chemokines and cytokines occur, which ultimately damage the membrane, causing an alveolar flooding with the highly exudative material, impairing the gas exchange. The surfactant production reduces, so that alveolar collapses due to end expiratory collapse. So there occurs reduced lung compliance and also the pulmonary hypertension. So this occurs due to interstitial and an intra-alveolar flooding, sometimes coagulation with an endothelial barrier dysfunction, and a migration of neutrophils is a very, very important thing in the first exudative phase. So when the action shifts from the neutrophils to the lymphocytes, progress into proliferative phase, what occurs here is there is a proliferation of the fibroblast in both the interstitium and the alveolar side and the capillary side. So there is a capillary endothelial proliferation, there is an interstitial fibroblast proliferation, and then alveolar pneumocyte proliferation. So that's why it is called as a proliferative phase. The edema fluid starts disappearing. By this time, the patient is usually out of mechanical ventilation. The patient is usually trying for spontaneous ventilation during this period. Sometimes from the proliferative phase, patient usually recovers completely. Sometimes they go into this progressive phase. This is no difficulty in understanding this, because we have seen a lot of patients in the post-COVID or recovery time going into the fibrotic phase, ultimately becoming oxygen dependent. So this occurs due to consequence of this proliferation of fibroblasts. There is a lot of secretion of this fibrin and deposition in the alveolar capillary membrane, ultimately causing this pathophysiology similar to an idiopathic lung fibrosis, impairing the gas exchange for the chronic period, becoming it irreversible. So this is the basic pathophysiology here. To understand the timeline here, whenever there is an inciting injury, the first thing that occurs is an edema formation. This is an exudative edema. This is not a transudative edema. This is not due to an increased pressure. This is due to an increased permeability. And over a period, the damage to the type 2 pneumocytes causes the surfactant loss, the alveolar collapses, the proteinaceous food gets accumulated in the alveoli and creating a membrane called as an hyaline membrane. That's why it is also called as a hyaline membrane disease. And this occurs usually in the exudative phase. Again, this was asked, hyaline membrane formation occurs in which phase of an ARDS, which occurs in exudative phase of ARDS. In the proliferative stage, it is an interstitial inflammation. The inflammation has shifted from neutrophils to the lymphocytes and the fibroblasts. And the lymphocytes also gone later. The fibroblasts are remaining in causing the fibrosis, causing a long-term standing problem to the patients. So till now, we discussed that what happens whenever there is an inciting injury to this capillary or the alveolar membrane. So what are these etiologies? So this insult can be caused by variety of insults. So anything can cause ARDS. More than 60 possible causes of ARDS have been identified till now. And it is going to emerge continuously. And it is being accountable by both the medical and the surgical side in causing an ARDS. And it is usually caused by the direct lung injury or the systemic diseases causing an indirect lung injury. So this is how it's been famously classified as the causation of the ARDS, the direct lung injuries and the indirect lung injuries. So direct lung injury, the damage is at the alveolar side of the alveolar capillary membrane. In indirect lung injury, it is the capillary side of the alveolar capillary membrane. Why it is important to know this is sometimes it's very important to treat the cause. To treat the cause, we need to know the cause. And whenever we know the cause, the definitive management is possible. Otherwise, we are just giving a supportive oxygen to the patient. So overall, the most common cause is sepsis. Sepsis originating from any organ can cause ARDS. So always try to suspect sepsis-induced ARDS whenever the hypoxemia develops in the background of an infection or a new fever or a hypertension. For example, you have a patient of diabetes mellitus having an UTI, managing through an OPD basis, coming to you with an evidence of sepsis plus an hypoxemia. So you need to suspect an ARDS in these patients. And this sepsis-induced ARDS is particularly riskful, and the patient is also alcoholic. And the gram-negative sepsis is more dangerous in causing a sepsis-induced ARDS compared to the gram-positive. We know that this is due to a lipopolysaccharide in the gram-negative cell membrane. So the next common cause is usually the lung infection, that is the pneumonia. We usually don't see a pneumonia like the community-acquired pneumonia or a lobar pneumonia as an implicable factor. It usually occurs whenever there is a bilateral infiltration, like you see in viral pneumonias, and you can see in sometimes the Legionella, where the disease is usually expected to be diffuse, or sometimes the pneumocystis jirovecii, or the pneumocystic carinal pneumonia, which we see in immunocompromised patients. So this we usually expect to progress from pneumonia to the ARDS. Otherwise, any bacteria, both the gram-positive, gram-negative, viruses, all can cause this. And the hospital-acquired pneumonias and the ventilator-associated pneumonias can also progress to develop into ARDS, increasing the mortality rate to more than 90%. And 1/3 of the patients who are admitted to the ICU develop ARDS due to an aspiration. So they usually have a recognized episode of an aspiration, like there occurs ventilator patient asynchrony, patient had an episode of aspiration. Next day patient going into ARDS is very, very common in case of an ICU setup. Remember, both the acidic and the non-acidic content of the stomach aspirate are responsible in causing ARDS. And trauma is very commonly implicated, usually occurs in a patients of polytrauma. You need to be very careful in suspecting whenever there is a bilateral lung injury, especially the lung contusion is very notorious in inciting ARDS. And whenever there's a long bone fracture, there can occur a fat embolism, can stimulate an ARDS. If there's a massive crush injury, and a flail chest can cause this, and burns similar to the pancreatitis can cause MODS, SIRS. There is a systemic inflammatory response syndrome. So these cytokines can damage the lung capillary epithelium, progressing into ARDS. We know that the multiple transfusions can cause this. This can simply due to a fluid overload, or this can also be due to an immune-mediated injury called as TRALI, that is the transfusion-related acute lung injury. Usually occurs due to plasma-containing blood product transfusion. And there are other causes like the toxic inhalation injury, the near drowning, the drug overdose, and some post-operative status, especially the major surgeries like cardiac. So irrespective of the cause, there are some patients who are inherently at the increased risk of influencing to have an ARDS, like especially a chronic alcohol patients are very easily progressing to the pulmonary edema due to non-cardiogenic cause, and the hypoproteinemia, the more age, the very severe underlying disease, and a hypertransfusion of blood products. Sometimes an enthusiastic doctor may transfuse blood without considering the patient's comorbidities. So the clinical feature, we know that the history is typically with the progressive symptoms of dyspnea and the reduction of an oxygen saturation. Sometimes this can be a very rapid onset. If it occurs in a pre-existing context, if it occurs in a trauma, if already patient is under admission with pneumonia, this is very easily understanding. But when the patient comes to you with a sudden history of dyspnea and a drop in saturation, you need to have a suspicion of an ARDS. It usually occurs within 72 hours following an inciting event, or can occur up to a week sometimes, very rarely, but usually occurs within 3 days. Whenever there is a trauma, you are admitted for the head trauma, within 3 days, patient can go into ARDS. The patients are very sick looking in ARDS. Unlike COVID, there is no silent hypoxemia in normal ARDS. Patients usually have tachycardia. There is too much tachypneic, diffuse crackle, and this tachypnea is not going to settle with an oxygen therapy. Please remember this. Even if you put this patient on high flow mask, very rarely they are going to respond. And when this hypoxia becomes very severe, it causes cerebral hypoxia, causing an acute confusion. It can progress into cyanosis, can have an associated diaphoresis. The laboratory tests are usually non-specific. We cannot diagnose ARDS by any lab test. The CBC may reveal a range of blood cell count. It can be normal, it can be low, it can be high. The routine chemistry show an evidence of coexistent organ injury. You may have a rise creatinine with an coexistent and acute kidney injury. There may be a transaminitis causing the liver injury. There may be an hypoxic brain injury causing reduced GCS. Sometimes the PT may be prolonged, the D dimer may be increased. We know that this is a state of an inflammation, sometimes an hyperinflammation also. What is actually beneficial is the ABG in these patients. The ABG shows an hypoxemia, and due to tachypnea, there is usually washout of CO2 causing an acute respiratory alkalosis. Remember, metabolic acidosis is very, very rare, and respiratory acidosis is not an initial feature in case of an ARDS. We usually expect a hypoxemia and an acute respiratory alkalosis, obviously with an elevated alveolar arterial oxygen gradient, because there is an impaired gas exchange. The type 2 respiratory failure comes later in the picture, which is a late feature in case of an ARDS. And imaging, we know there are no typical appearances, but we usually depend on chest X-ray. Sometimes we may need CT, especially to rule out the other diagnosis. So this is usually the chest X-ray you see in case of an ARDS. So there are bilateral. Remember, this is a bilateral disease. Bilateral infiltrates. So these infiltrates are both alveolar and interstitial. And this is patchy. So it is dependent. It appears to be dependent. See, the lower lung fields are more commonly involved compared to the upper lung fields. So this dependency can be actually very well studied in case of the CT. Just see this. In CT, this patient is usually supine. So the gravity-dependent portions have more ground glass opacities or infiltrates compared to this non-dependent portion. So this is a very, very important concept in case of ARDS. The PF ratio, I think I have discussed this entity in the hypoxemic respiratory failure class also. The PF ratio is a very important thing we calculate to classify the ARDS as mild, moderate, and severe. So P represents the partial pressure of oxygen. The F represents the fraction of an inspired oxygen that the patient is receiving, which is usually expressed as the decimal. So normal breathing oxygen is 21%. So we are actually at the FiO2 of 0.2. So if the patient is having saturation of 90% or the partial pressure of oxygen in the artery as 90 with the 40% oxygen therapy, if you want to calculate the PF ratio here, so PaO2 is 90, FiO2 is 0.4. So the PF ratio becomes 225. So any PF ratio of less than 300 is considered to be an ARDS. Sometimes if the patient is this I think I have also discussed in case of the class. This is for the nasal cannula. So for every 1 liter increase, the FiO2 increases by 0.4 or plus 4% of FiO2. So if the patient has an 85 mmHg of PO2 and ABG while receiving 6 liters of nasal cannula therapy. So 6 liter means it is usually 0.4 of an FiO2. So the PF ratio becomes 193, which is less than 200, making it very severe ARDS. So what will you do if you don't have an ABG? So we have got an equivalent conversion table from an SpO2 to the corresponding PaO2. If the patient is, remember, if the patient is having an 85, remember PO2 is 50. This is very easy. That's what I remember. PaO2 is 85, it means 50. Is 90, it is 58, around 60. So anything which is taken in between. That's how I usually do the calculation. And this is a very rough rule. Whenever you have an ABG for a resource limited setting, you can follow this protocol. So for example, if the patient is having a pulse oximetry SpO2 of 95 on 40% oxygen. So 95 means PaO2 is 80. So even if his SpO2 is showing normal, remember this is on 40% oxygen therapy. So his PaO2 is actually 200. So this patient is also having ARDS. So this is very, very important. If he requires more than 30% of oxygen therapy to maintain saturation, you need to be very careful in ruling out an ARDS. So this is, we also have a clinical definition and criteria for this. The latest definition was the Berlin definition. It was published in 2017. So which usually gives 4 typical criteria to diagnose the patient as ARDS. Believe me, this is of no help. Although the consultants may ask this question, this is actually of no help in the clinical way. This is only for an experimental purpose, only for the research purpose, because if you see this criteria, any patient can be fit into ARDS ability. Let's take this. Timing within 1 week of a non-clinical insult. So if there is any clinical insult within 1 week, if they develop a new onset or a worsening respiratory symptoms, and if you take the chest X-ray, they need to have a bilateral infiltrates or opacities, which is not fully explained by, you cannot explain it by a pleural effusion, you cannot explain this finding by a lung collapse, you cannot explain it by a nodules, like the miliary tuberculosis. So you cannot explain this. If there is a miliary tuberculosis, there are many of the milia situated, then this cannot be an ARDS. If there's a multiple carcinomatous nodules, this cannot be an ARDS. If there's a bilateral pleural effusion, if there is bilateral upper lobe collapse due to some malignancy, this cannot be an ARDS. So these bilateral opacities, they should be not explainable easily. And the origin of edema should be non-cardiogenic, because this dealing of evaluation of the cardia is by clinical and by the objective assessment also. So the findings are not usually explained by the cardiac failure and fluid overload. And if you want an objective assessment, you can go for echocardiography to exclude a hydrostatic edema if no risk factor is present. Initially, the origin of edema, they had a criteria of pulmonary capillary wedge pressure of should be less than 18. In the earlier AECC definition, the earlier AECC means American European Critical Consensus definition, although they provide similar criteria, what they did was they did not specify the timing, they just mentioned it in acute. What they did was bilateral opacities, that's what they mentioned, and origin of edema, they mentioned non-cardiogenic. How we will diagnose it non-cardiogenic? They gave it a criteria of pulmonary capillary wedge pressure of less than 18. So what problem it occurred is, it is very difficult to measure pulmonary capillary wedge pressure in all the acute hypoxemic respiratory patients. And also sometimes the non-cardiogenic pulmonary patients of an ARDS also showed an pulmonary capillary wedge pressure of more than 18. So that's how the criteria of the pulmonary capillary wedge pressure was removed, and they inserted this in echocardiography and the clinical explanation. And initially, AECC criteria did not account the PEEP in calculating the PF ratio. Now they have given the PEEP. So to calculate the oxygenation, you need to ventilate the patient and you need to put them on PEEP. then you measure the PF ratio, or be it a non-invasive or a invasive. So you cannot measure the PF ratio in the home or when the patient just arrived at the hospital. You need to wait till you give the patient the oxygen. So you calculate the PF ratio by providing some amount of PEEP, at least 5 centimeters of water. So if this PF ratio is less than 300 and more than 200, this is called as mild. This was initially labeled as an acute lung injury. And if it is less than 200 and more than 100, it was called as moderate. And if it is less than 100, it is called as severe. So earlier it was called as acute lung injury and an ARDS. Acute lung injury if the ratio was less than 300, and an acute ARDS when the ratio was less than 200. And later they changed the terminology in the Berlin definition just to mild, moderate, and severe. The acute lung injury terminology have been removed. So the mild ARDS is, this is the approximate number. You may find a little bit variation. This is very easy to remember. 25, 35, 45. So severe ARDS patients, there is a 45% chance that they're going to die. The mortality rate is 45% in case of the PaO2 less PF ratio of less than 100, and in mild it is less than 30 or 25%. So this definition, if you apply this in a COVID world, I think all the patients who are admitted to the nursing homes fits into the definition of ARDS in COVID. Or sometimes all influenza, severe influenza fits into ARDS, any viral pneumonia, sometimes they can be fits into ARDS, like they're usually 1 week, you have a bilateral opacity, there are no cardiac involvement, PF ratio less than 200. So all Tom, Dick, Harry, which is coming as an acute respiratory failure, can fit into any ARDS. So this definition is not going to help you in managing the patient. The management is not going to change. Anyhow, you need to ventilate the patient. You can get the insult, you can get the early evaluation. If at all you cannot find out any cause, like you have ruled out COVID, you have ruled out influenza, you have ruled out diffuse alveolar hemorrhage, you have ruled out acute eosinophilic pneumonia, you have ruled out an acute interstitial pneumonia, you're not getting any cause, then we can consider it as an ARDS. Or sometimes if you have got a history like a sepsis, going into an hypoxemic failure, you need to suspect an ARDS like this. So the diagnosis is basically made by the pre-existing or the patient profile, not the criteria. This is what I want to focus in this here. These are all for the examination purpose. Yes, you should know the Berlin definition of an ARDS. How will you define the ARDS? What is important is the etiology should be non-cardiogenic. You need to be very specific in ruling out the cardiogenic disease. And this is actually not difficult, because in cardiogenic pulmonary edema, you just put on diuresis, the patient is going to respond within hours to days. Within the 24 hours, the patient is going to be out of the dangerous period if it is cardiogenic, and just by giving the diuresis or sometimes doing a hemofiltration. Whereas if in case of the ARDS, an inflammatory ARDS, the patient is not going to come out just by diuresis. So this is usually a retrospective diagnosis rather than the initial diagnosis. Again, I think we have discussed this as an acute phase. In the acute phase, it is less than 7 days. In the exudative phase, discuss this. In the proliferative phase, there occurs a proliferation, and in the fibrotic phase, there occurs an extensive pulmonary fibrosis. This we have discussed also. And to come to the differential diagnosis, I have told you that cardiogenic pulmonary edema is very, very important in ruling out. I think one best way to rule out is treat. Especially, again, the patient profile is important. There is a very old age patient, history of IHD with the triple vessel disease, coming to you with a sudden onset hypoxemic respiratory failure. So there is every chance that you may suspect him having a heart failure or a pulmonary edema. Whereas there is a young patient who is diabetic, having an UTI, treating for UTI, Coming into an hypoxemic respiratory failure, put an oxygen, not responding to oxygen, no cardiac risk factors, you need to suspect ARDS. So that's how you suspect these patients. As far as investigation wise, how will you differentiate this cardiogenic pulmonary edema and ARDS? Chest X-ray, it is, I think, a very vague terminology. Sometimes you can go for a cardiomegaly. Yes, if you have a cardiomegaly, there is no cardiomegaly, and it is usually bat wing. Whereas in ARDS, it is usually peripheral distribution, not the central. And there is usually upper lobe sparing in case of ARDS, whereas cardiac pulmonary edema, there is upper lobe involvement is usually seen. Whereas if you see the CT lung, how will you differentiate between cardiogenic and non-cardiogenic case? The cardiogenic edema is diffuse, very, very important thing. Whereas ARDS is patchy. Another terminology for this is heterogeneous. And there occurs a septal thickening and multiple pleural effusions. Whereas in ARDS, it is an area of dense consolidation which is interspersed with a normal appearing lung. In USG lung, again, the B lines are diffuse. Here, there is patchy B lines. That's how you usually suspect in ARDS. Coming to the very important thing here, that is the management. We have got some general management here. Very, very important is the respiratory support. How will you manage the refractory hypoxemia? How will you manage the fluids? And what is the supportive care? So general management is first and foremost thing is try to find out the cause of the ARDS and treat it. And you need to minimize the procedures, minimize shifting the patients so that you are reducing the complications. Start prophylaxis against the thromboembolism, GI bleeding, and the catheter-related soft tissue infections. Put him on adequate nutrition. You need to have a very adequate glucose control with maintaining glucose of 120 to 180 milligram and a lung protective ventilation. So again, the first thing is do no harm. It's my favorite terminology. Even in my ICU, I have been applied it on every bedside, that do no harm. That is the first thing that you need to understand this. So how will you provide this respiratory support? You need to reduce the oxygen consumption. If there is any entity which is increasing the oxygen consumption, treat it. Like if the patient is febrile, treat it. If the patient is in pain, treat it. If the patient is in anxiety, treat it. If the patient is having an excessive respiratory muscle, put him into paralysis, treat it. And by reducing the oxygen consumption, you are reducing the demand. This is a very, very important thing. Next, increase the supply, then provide the oxygen. So this provision of oxygen is usually invasive in case of an ARDS. Sometimes or very recently, we are trying for the non-invasive oxygen support only for mild ARDS. Remember this. That means a PF ratio of more than 200 and less than 300. We are trying a non-invasive mechanical ventilation, be it a BiPAP or an HFNO, provided patient also meets other criteria that we discuss in due course. So the first thing is reduce the oxygen consumption, increase the oxygen supply. How are you going to supply? Remember, the patient is already in refractory hypoxia. That means the patient is already received oxygen therapy through the nasal cannula or the mask, sometimes the high flow mask or the non-rebreather mask. Already the patient has received this without any response. You may need to start the patient on invasive oxygen support. Sometimes in a mild category of patients, you may have to go for a non-invasive oxygen support. So what are our goals in case of respiratory support is you need to maintain an adequate oxygenation with preventing an associated ventilator-induced lung injury. So by providing more oxygen, you cannot actually do very good in your patients. So oxygen, we know that it is toxic. can cause damage by its own way by providing the reactive oxygen species and causing an oxidative stress. So that's why the maintaining oxygenation is an important terminology, but not at the cost of a ventilator-associated lung injury. So the FiO2 should be non-toxic. You should need to provide PEEP, and you need to provide other ways of mechanical ventilation. And after this, you need to achieve to have a pH in normal range or sometimes a slightly acidotic. 7.2 to 7.3 is okay. If it is less than 7.15, I will correct the acidosis. And you need to enhance the patient ventilator synchrony and the patient comfort. You can use either sedation, you can use amnesia, you can use analgesia, you can use paralysis if necessary, but the synchrony is very, very important. This is going to have a multiple benefits. It improves oxygenation. It reduces the demand, as I told you in the last slide. It prevents the ventilator-associated lung injury. There are multiple benefits of this synchrony achieving through the paralysis. And daily you need to give, the patient is improving, you need to try to wean it from the mechanical ventilation and the patient is breathing without any assisted ventilation. So the first goal is to maintain an oxygenation, but not at the cost of lung injury. After this adequate oxygenation without risk of the lung injury, I want to keep the pH in the normal range. Slightly acidotic is okay. It is called as permissive hypercapnia that we discuss in the coming slides. But less than 7.15 is what I treat the acidosis. You need to enhance the synchrony between the ventilation and the patient to have a multiple benefits and try to wean off from the mechanical ventilation in the improving patient. So we discussed that to maintain an adequate oxygenation, the hypoxia in case of the ARDS is usually resistant to the oxygen therapy. And administration of this supplementary oxygen via high flow systems like NRBM is generally ineffective. As I told you, many of the patients may need mechanical ventilation via invasive route. Very mild category of patient may respond to non-mechanical ventilation. And when you intubate this patient of ARDS, most patients usually require a very high levels of FiO2. Even if you give 100% of FiO2, saturation is not going to be normal. So you are exposing the lung to a very high concentration of oxygen with a very high pressure sometimes. So this is potentially toxic, or it is toxic. So what we do is we try to give a PEEP to improve the oxygenation, to reduce the FiO2, so that we're not exposing to a very high concentration of oxygen. So when we use this PEEP in a sufficient amount, PEEP generally allows the FiO2 to be lowered to the less toxic concentration. So what is PEEP? We need to understand here. We know that we are giving the oxygen in the inspiration and we are exhaling the air. So what happens in normal aerated lung is, we are on inspiration, there occurs an expanded alveoli. On expiration, the alveoli contracts, although they may not contract completely. Why they do not contract completely? Because they have normally the surfactant which prevents the complete collapse of the alveoli. So in case of an ARDS, there is no surfactant. So at the end of expiration, the alveoli completely collapses. See this. So to open this collapsed alveoli, we need very high pressure. So when you give a high pressure, there's a tendency that you may damage, or there is a tendency that it may not open to the high pressure also. So that's why you don't want your alveoli to be completely collapsed at the end of expiration. That's why you add a PEEP in the mechanical ventilation. Whenever you go to the ICU, you try to see how the PEEP is set. So if I set PEEP at 5 centimeter of water, that means at the end of expiration, the alveoli have 5 centimeter of water of pressure, so that it will not collapse the alveoli completely, so that for the next breath, when the air comes in, the alveoli is ready to take the air. Otherwise, if it is completely collapsed, it will become problematic. So this is one of the recruitment maneuvers. So you are recruiting the collapsed alveoli by providing the PEEP. So this is one of the very first setting that we usually keep in case of an ARDS mechanical ventilation after setting the tidal volume. To reduce an FiO2, to reduce the potential toxic of very high concentration of oxygen, we provide the PEEP. But what you should understand here is the lung is an engine of inflammation, and there is a concept called baby lung concept. So the baby lung concept means, remember in the ARDS, as I told you, the disease is heterogeneous. So what do you mean by heterogeneous? So in the normal lung, all the alveoli are at the same stage of either contraction or the dilatation. Whereas in ARDS, some alveoli are normal, some alveoli are fluid filled, some alveoli are collapsed. So what happens if you give a very high pressure air? Sometimes it may benefit for this may shift the fluid. This may benefit from this alveoli. So this will expand. What happens to the normal alveoli? If you give a very high pressure, this is going to be ruptured. So this is the normal alveoli, which was normally taking part in the lung air exchange. You are damaging this by giving a very high concentration or a very high pressure oxygen. So the baby lung means that a very small part of your lung is actually active. So when you give a very high tidal volumes, very high FiO2 to this section of normal lung, they may rupture, causing a barotrauma. So this was the initial 1 decade earlier. The management was just to give a high tidal volume of routine. Tidal volume is usually we keep for 10 to 12 ml per kg of the predicted body weight. So at this level of tidal volume, variably, alternate patient were going to have a pneumothorax due to ruptured alveoli. So this was due to this baby lung concept, and this was provided by a very famous intensivist, that is Gattinoni. You need to read articles of Gattinoni to understand the respiratory physiology too much. If anybody is interested in respiratory physiology or respiratory diseases, try to study the Gattinoni articles. Some are very, very good actually. So this baby lung concept came in. So this understood that there is a volutrauma. That means the injury is occurring due to overexpansion of the alveoli during the inspiration. That means there is a normal alveoli which are getting overexpanded and ultimately causing rupture, causing a volutrauma. And atelectrauma, that means when the alveoli are repeatedly opening and closing, this causes an atelectrauma. And there is also barotrauma due to very high pressure. And there is also something called as biotrauma. That means we know that an oxygen is an oxidative stress. So this will generate an reactive oxygen species, ultimately causing the damage. So to understand this, the terminology was given as an engine of inflammation to the lung. So lung is an engine of inflammation. Anything there incites a very high inflammation. So to prevent this ventilatory associated lung injury, there came a protective type of ventilation called LPV, that is a lung protective ventilation. That is what we are practicing right now. This is the latest or the new standard of care in case of an ARDS. You need to know what is the lung protective ventilation. So we don't want the normal lung to be sacrificed here. So as I told you, sometimes you can have a non-invasive positive pressure ventilation for only mild ARDS, provided they have other clinical criteria. That means they should not have other organ dysfunction. They are hemodynamically stable. They should not be in shock. They should be fully conscious. They should be able to tolerate the face mask. They should maintain their patent airway. That means if the patient have too much secretions, hemoptysis, you cannot go for this. And patient, if is immunocompromised, you can go for the non-invasive ventilation sometimes. So how is the respiratory management in case of ARDS? Is again, you try the oxygen via the face mask or the nasal cannula. If the patient is depending in the mild ARDS category, go for try some HFNO therapy, provided patient is hemodynamically stable, conscious, tolerate the mask, maintain the airway. You can try HFNO. Sometimes you can try the CPAP or BiPAP in some selected patients, and you can provide the self-proning in these patients. That's what we did in COVID. This was the standard of care in COVID. But this is usually not case in ARDS. In ARDS, you need to start the patient in the mechanical ventilation with the lung protective ventilation. So what is a lung protective ventilation? Is a low tidal volume ventilation. So it is 50% of the normal tidal volume which we give. We usually give 6 to 8 ml per kg of the tidal volume in case of an ARDS, and start giving PEEP by trying to reduce the FiO2. And you need to maintain the physiological targets here. What are my targets? I want the saturation to be 92. I don't want it normal. This is not more than 92. It's wrong. I just want the saturation to be from anywhere from 86 to 92 is completely acceptable in case of an ARDS. If you try to achieve more targets, there's a tendency to cause more damage to the patients. And try to have a PF ratio of at least 150 or more. There should not be too much hypercarbia. The PCO2 should be less than 50. The plateau pressure should be less than 30. It's a very important concept. And there are other potential targets which you usually not measure. So if still the patient is not responding, then you can have an additional measures, like the patient can have prone ventilation, you can try the paralysis, you can try the recruitment maneuvers. Even if they're not responding, you can go for the extracorporeal membrane oxygenation. Yeah. So this was the HFNO therapy. This we discussed in the respiratory failure class. So this is how the BiPAP or CPAP machine looks. So this is a protocol for lung protective ventilation. What is this? The first is calculate the predicted body weight. Set the initial tidal volume as 8 ml per kg. This is what is the basic and the first thing we usually do. Start the patient on ventilator. You need to have the predicted body weight of the patient. Start him on 8 ml per kg. Give the PEEP of 5 centimeters of water. Give some time. And try to reduce the SpO2 targeting 88 to 95 with the lowest FiO2 possible. So if he's maintaining, try to reduce it in the tidal volume to 6 ml per kg by reducing the VT by 1 ml per kg every 2 hourly, provided you maintain the SpO2 between 88 and 95. The second stage is when VT is, that means the tidal volume is set at 6 ml, you need to measure the plateau pressure. What is plateau pressure? Let's understand this. So when the air is flowing inside, you are having the peak pressure. The air is coming from the alveoli. So there is a flow in, there is a flow out. Again, there is a flow in. Sometimes what happens is you cut the flow. So you measure the pressure in the alveoli and the air is not flowing. That is what is called as the plateau pressure. So when you measure the pressure in the airway during the airflow, that is called as peak pressure. When you measure the pressure when there is no flow, that is called as plateau pressure. So what the peak pressure, you are measuring the pressure during the flow. That means it provides the airway pressure. So whenever there is a very high peak pressure in your ventilator, you need to suspect there is an obstruction. There may be a mucus plug, there may be a kinking, there may be blockage, etc. So whenever there is a the plateau pressure actually provides the lung compliance. How much lung can be expanded? So the plateau pressure, a very high plateau pressure, that means the lung is already having reached its compliance level. You cannot expand more. There is a tendency to cause a damage by giving more oxygen or more pressure in this patient. That's why the importance of plateau pressure here. So whenever the tidal volume reaches the 6 ml, you need to measure the P plat, that means the plateau pressure. If it is more than 30, you need to reduce the VT tidal volume by 1 ml kg until the plateau pressure is less than 30. So the first target is I want the tidal volume to be 8 plus P. As soon as patient is trying to maintain normal with this, try to reduce the tidal volume to 6. He is good at maintaining at 6. Measure plateau pressure. If it is going above 30, you need to reduce it further until it reaches 4. That's how you try to reduce the tidal volume and prevent the lung injury. So in all during this stage, if he's maintaining very properly, now you need to come to the other factors like the pH. Measure the pH. If the pH is between 7.15 and 3, they have given that you can increase the respiratory rate until the pH is normal. So by increasing the respiratory rate, you are doing the washout of the CO2. If the pH is less than 17, you need to increase the respiratory rate to 35. You cannot go more than 35 with this. And sometimes even if the respiratory rate increase is not fine, you can try to increase the tidal volume again back to 7 or 8. So the ultimate goal is you need to have at least 6 ml with a plateau pressure of less than 30, saturation being maintained at 88 to 95, and PaO2 target is usually 55 to 80 with the pH being normal. So this is the usual initial lung protective ventilation which we usually try for the patient. So if it is not beneficial to your patient, you are going to try the adjuncts to this lung protective ventilation. So what was the lung protective ventilation? Low tidal volume plus P plus P plateau of less than 30 plus pH of 7.3. So this was the lung protective ventilation. So if this is not being okay, I want to try the adjuncts. The first adjunct is usually the permissive hypercapnia. So what is this permissive hypercapnia means? This is defined as a clinician allowed hypercapnia. So this is not a developed hypercapnia inside the patient. The clinician intentionally creating the hypercapnia during an assisted ventilation. Despite we know that we can achieve this level of minute ventilation sufficient to maintain normal PaCO2. That means we know that we can have a normal PaCO2, but yet we are having this slightly acidic environment due to reduce the tidal volume to prevent the ventilator-associated lung injury. So these patients sometimes may develop hypercapnia during lower tidal volumes. As I told you, the low tidal volume is the main thing in ARDS. So by providing low tidal volume, some patients may usually develop hypercapnia and we're not doing anything for this. Let it be there. That is what is permissive hypercapnia. So what are the contraindications where you cannot have this hypercapnia is if the patient is having a coexisting raised ICT, you cannot have this, will cause a severe cerebral vasoconstriction, may cause death, and an acute vascular event. If the patient had an acute CV, acute MI, you cannot this. Severe pulmonary hypertension, even if you try, the patient will die. The patient cannot tolerate even some amount of CO2 retention in case of pulmonary hypertension or the RV failure. And there are other, like if there is an uncorrected metabolic acidosis, TCA overdose, and pregnancy, because this can be damage to the fetus. You cannot go for permissive hypercapnia in case of pregnancy. And if this is also not working, you can try the prone position ventilation. So this prone position ventilation, how this benefits is, we know that this is a heterogeneous lung. So by putting the patient into the prone, you are increasing the functional residual capacity of the lung. You are changing the diaphragmatic motion. You are slightly distributing the perfusion, and sometimes improving the clearance to chance the clear the secretions. However, it needs a very special monitoring. It needs an extra care. You need to ensure the safety and the patency of the ET tube. But these have shown no mortality benefit. Remember this. And another adjunct which we usually try is a recruitment maneuver. So what is this means is, it is defined as an application of a continuous positive airway pressure. We know that we were giving only end expiratory pressure. Now we are trying to give a continuous positive airway pressure. We are aiming at recruiting or opening a totally or partially collapsed alveoli. So that's what we are doing here. We are giving the positive pressure both during the inspiration and the expiration at the alveolar level. So what happens this keeps the alveoli inflated during the expiration using an appropriately high level of PEEP. And these are usually performed by maintaining the CPAP level of 35 to 45 centimeter H2O for 30 seconds. So this is usually done as an episode. Recruitment was given for 30 minutes, recruitment was given for 1 minute, recruitment was given as this minute. So this you can try in between the patient management. And there are other adjuncts to the lung protective ventilation. As I told you, that inhaled nitric oxide, the main mechanism was to prevent the pulmonary hypoxic vasoconstriction. Then tracheal gas insufflation, that means you are pushing the gas to a very high pressure. Then extracorporeal life support. Recently, this has been trying to show the mortality benefit, but till now it hasn't shown, and a very costly, a very cumbersome procedure. The corticosteroids is a very, very big confusion. Every guidelines tells you don't use corticosteroid, but if you see every ICU, all ICU are using corticosteroids in ARDS. But what I am basically want to tell you here is, if you want to start corticosteroids, start early, like COVID. Do it in a very proper way. Don't do it half-heartedly. Go for either methylprednisolone or dexamethasone. Don't give hydrocortisone. This is what I feel as far as corticosteroid is concerned. But again, there is no mortality benefits. The neuromuscular blocking agents, especially by providing the synchrony between the ventilator and the patient, trying to improve the oxygenation here. So this is the famous table from the Harrison. So the category of recommendation, if you remember here, the first category, category A, is only tidal volume ventilation. None of the other among this have given the category A evidence. That means category A means the recommended therapy is based on a very strong clinical evidence from the randomized clinical trials. We know this is an evidence-based medicine. So that is how we usually practice. So all the evidences are very strong against the low tidal volume. So the first is always low tidal volume. So we are going to try this in every patient. So what is now next? What is next is category B. So what are category B? High PEEP, minimizing the left atrial filling pressure. So this was regarding the fluid management. Okay, forgot to mention here regarding fluid management. Fluid management in ARDS, remember, it is better to underhydrate your patient, not to overhydrate. Overhydration is going to be very problematic in case of ARDS. They're not going to tolerate it at all. So slightly underhydration is better, except if the patient is shocked, or when the patient, this is very, very important, the patient is actually recovered from the shock. You need to reduce the fluid very drastically. So that's why they have mentioned minimize the left atrial filling pressure is going to some benefit in ARDS. So category B is of 4 things here. One is underhydration, slight underhydration. It is not dehydration, it's slight underhydration by providing a PEEP, prone position, and ECMO. These have been come till category B of evidence. Remember, in the next edition of Harrison, they may put ECMO into category A recommendation, but this may remain category B because the cost and the availability of the procedure. Next, other manures like the recruitment manures, the neuromuscular blockade, the inhaled vasodilators, all the C. The category D is steroid surfactant replacement like the neonates and the high frequency ventilation. So these are all category D. So what is category D is not recommended on the basis of clinical evidence. So what is not recommended by the Harrison is steroid. Yet everybody is giving steroid. What not recommended by Harrison or the evidence is surfactant replacement or other anti-inflammatory therapy. And high frequency ventilation is not recommended. So don't follow this. Low tidal volume, high PEEP, not responding, try some recruitment, try some proning, not recruiting, go for ECMO. This is what is the standard of care in ARDS right now in all the ICU. So now there are some emerging therapies. The ulinistatin is being like a ubiquitous. It is there in sepsis. It is there in all critical illnesses, but there is no still evidence. It is a urine tryptase inhibitor. Acute pancreatitis also it has come. So this may come out or may not. The ulinistatin was also tried for COVID by the same Bharat Biotech, but it didn't work out well. A high dose vitamin C. So I know whether you follow this guy called Paul Morick or not. This got very famous in COVID. So this guy who's a pulmonologist believes in a high dose vitamin C in ARDS. Although you can try, we have tried 3 gram vitamin C in our ICUs. Even we have tried this in COVID also. We don't know because this is working or not. It's very difficult to test. Carbon monoxide, I don't know, but this coming as an emerging therapy. And the mesenchymal stem cell therapy is at the verge of trial. So this is some emerging therapies. Thank you. I think if I have any doubt, I will take. So from next class, I will be trying to deal the hematology section. If anybody wants any other separate discussion regarding the critical care illness, let me know so that I can prepare accordingly. Thank you. Thank you very much.